watch how the vocal muscle is what you're seeing there, where it's labeled vocal folds. And as air goes up, it opens from top, bottom to top, and when it closes from bottom to top as well. So it's not just opening this way. There's a whole wave-like structure that occurs that we tend not to see even when we look at it from a superior or inferior aspect of it. And then I have another video that shows the, looking at a bronchoscopy. And this guy volunteered to have a bronchoscopy procedure. It's a 12-minute video, so I thought I had it already down here, but I'm going to let it play for a little while, open up another one, because it shows him getting his ID and everything. He was a doctoral student teaching physiology, and he thought it would help him. So he volunteered for a bronchoscopy. Really? So let me pull up another one while that one's playing.
What's an oscopy?
Oscopy means to look. So they usually put a tube in there. Epiglottis there. Make sure the lights down.
Oh, that's a good shot. Where's JP? Oh. Where? Another leg. It looks like a vagina. Oh, I love that. Yeah, he's like, I don't know who we're even looking at, but there they are.
Now you can see the tracheal cartilage rings.
Wow.
So the top of the screen will be towards the anterior. Those are part of the rings.
Is he awake right now?
But under local anesthesia.
What's the yellow stuff?
Mucus.
Ooh.
And then the guy starts bumping into the walls here.
Yeah, I saw that.
I wanted to show, see if it gets far enough down to show the carina, but I'm going to pull up another one that shows bronchial cancer.
If you're a smoker, would that look any different?
More the blood vessels would be more constricted.
Okay.
Let me pull up one for. There's a carina.
Oh, wow.
Ridge, you separate from left to right.
That's so cool.
So we're still in the primary bronchi. So this is still being pseudostratified. So you can see this on the sheet plug. If you were to open up the sheet plug, it would look similar to this. You're putting in a sheet plug. Yes.
So when you get bronchitis, is that like inflammation?
So there's an infection, an inflammation, usually a swelling of the tissues lining the airway. So now I'm going to pull up a different slide.
This is normal ones, right?
Yeah, these are normal. a lot of the little white spots are mucus. There you can see the tumor over on the left. I'll come back to it again. See the little nodules?
Oh, wow.
Oh, this guy's finally got the tube in there. So they have rigid tubes that they can use where they go through the mouth and through the endotracheal ones, and then they have fiber optic tubes for the nasal hairs.
Yeah.
And the one side of his nose had a large turbinate or nasal conchae, so they had to pull back to get there. So they decided to pull out and go in the other one.
Just so happened that my right nostril at this point had this tissue swollen up. It's basically engorged with blood. So we took it out, put it in my left nostril, and you'll be able to see now he has a really clear path all the way through the back of my nasal cavity. It'll go past my larynx area and down into my throat. You see that again? It goes up through my nasal cavity,
Doesn't feel good.
go over the back of my throat, and then
He's
down
been,
the back of my
they
throat.
sprayed a
What you
local
can see here
anesthetic as
is
well.
my epiglottis and my vocal cords. So the epiglottis is the U-shaped structure at the bottom. It looks like a quite shallow U, and that folds over and closes over the trachea, which is just above it, so it stops food and drink going down into your airways. And then you can kind of see the V shape just above it, those are your vocal cords. And then above that you've got an arch that comes over, and those are pieces of cartilage that control the opening and closing of
These are the
the
arytenoid part.
vocal cords. So you can make different pitches of sounds. So you can
Yeah.
go hi, and you can go no, like that. Now, because the camera's going to go down into my trachea and into my lungs, the splash you can see on the screen now is just anaesthetic that's been squirted through to numb that whole area. So once everything's numbed, the camera was put through the vocal cord down into the trachea. You can see the cartilage rings over the top. I'm just going to pause it just here. You can see the cartilage, the C-shaped cartilage rings going over the top. So the top of the screen is where my sternum would be, and at the bottom, where the rings disappear, that would be where the esophagus goes behind the trachea. So we approach the first split into the bronchioles, and you can see you'll go down the left bronchiole, and you can see the still cartilage rings around this section of the bronchioles, and then you can start to see where they split into like primary, secondary, and tertiary bronchioles. So these get smaller and smaller and divide into more and more sections. They also take the airways up into different lobes of the lungs, so the upper, middle and lower lobes of each lung. You can see they're nice divisions. You can see all the separate bronchioles going down further and further deeper into the lungs. You might be able to see some bubbles every now and then. You can see how the air's flowing through my lungs and actually blowing the bubbles of the anaesthetic. You can see there's some damage there, some red marks where the camera's bashed against the side of the airways and caused some damage.
What
We're
happens
just
if
going
you
to
don't
find the
harm?
right position, and this is the first test that he did. So this is called a brushing. You saw brush come out, and he rubs the side of the airway to collect the cell sample and irritate the lining of the lung. And you can see the brush come out again, it just pops out, and he gives a good rub, collects another sample, and then it's withdrawn back through a tube and sent off to lab for analysis. Now the next section is a little bit more brutal, and it's the biopsy section. So he puts down a little set of pincers, you can see them open there, and he tries to grab hold of part of the bronchial tissue. You can see he's going to grab now, attaches on. I don't think he actually managed to grab that first section. So he'll try again, open the pincers up, take a nice big bite and pull. this is the chunk that he took out. So you can see the
Oh.
plastic chunk out of the wall there. So we had about 10 of these, so he keeps going around finding sections, grab hold of the tissue and pull. You can see that's a bit like a video going there, all the blood splattering. And this didn't actually hurt because the tissue that he's grabbing has no actual nerve endings or nervous tissue there to actually create.
You should have told us that
sensation.
before.
I don't actually feel any pain with the sample, which is quite amazing, really. And last one, take a bite and pull. There you go. And this is the actual procedure from outside. So it's the nurse passing Dr. Hinks the actual pincer, which is on the end of a wire, and the nurse behind Dr. Tim Hinks actually had the control mechanism to open and close the pincers. So she's closed the pincers and
They just
Dr.
actually
Hinks is
slide
just in the right position. You'll see him just tug on the wire that was placed down in a minute, and that was the actual mechanism to actually get the sample. So there you go, he tugged it then, and he took the sample. And this is the actual end of the procedure where Dr. Hinks is actually pulling the camera out on us. So you can see how long the camera is. It's very gently manoeuvring it round, not to do any damage through my throat, and pull it all the way out through my nose, and there you go. And then immediately after I was putting some oxygen through a nasal tube, so I put it around my nose, and this is what I had to say about it all.
What do you say?
Alright, so I just thought since we've covered that, it would be, okay, interesting, maybe not fun, but interesting to see it on an actual living component. Let's do just a bit of review from the airway structures that we covered on yesterday, comparing the epithelia, cartilage, and smooth muscle, and moving on to the rest of the two airways that we're going to cover today, the alveolar ducts and the alveoli. So starting with the trachea, and what airway did we include with the trachea that had the same appearance? Primary bronchi. Or bronchus. So epithelia for both of these airways is going to be pseudostratified, ciliated columnar epithelium, goblet cells, and microvilli present as well. All right, what about cartilage? So it's all going to be, the cartilage is present, it's always going to be hyaline cartilage. And what is the appearance? What is the structure? Okay, so a C-shaped ring. And what about smooth muscle? Is there smooth muscle present? Okay, so only across the opening. So, trachealis, okay? What you can see in this location right here. Then as we move into the branches, follow those bronchi into the lungs, we have our secondary and tertiary bronchi. Now we actually will see pseudostratified, simple columnar, and simple cuboidal as we move from the first secondary to the last tertiary or quaternary bronchi. But what did I say was the characteristic epithelia? What kind? Pseudostratified is here. Simple. So we have pseudostratified at the beginning, simple cuboidal at the end, but the majority in between, our characteristic one is going to be simple columnar. We still have goblet cells. I'm going to add that because we always have goblet cells in cilia with pseudostratified, but not always the simple columnar. So goblet cells are present, cilia and microvilli, primarily cilia. And cartilage. Okay, so the way I describe that is a discontinuous ring. In other words, it's not a solid ring all the way around, but it is a ring of individual plates, so discontinuous ring. So that's what we see here, where we have separate pieces of cartilage going around the airway. What about smooth muscle? continuous ring of smooth muscle between the epithelium and the cartilage.
Is that the one that doesn't have a name?
Yes, so the rest of the smooth muscle, it's unusual in the end of smooth muscle. So the only muscle we name is in the posterior to the trachea. Okay. Now what do we call the next airway? The term he was using wrong in the video.
Bronchi.
Bronchiole. So now our characteristic epithelia for bronchiole is even shorter. We have the simple cuboidal. Goblet cells? No. But we still have cilia and microvilli. Cartilage? None. That's our characteristic structure, our key difference rather, is the absence of cartilage once we pass the bronchi. Smooth muscles? That becomes now our defining structure. So yes, in the same continuous ring encircling the airway. Okay. Now at the end of lecture yesterday, we talked about terminal and respiratory bronchioles. Okay. And remember we had to have, this would be just a regular bronchiole. This would be our terminal bronchiole proximal to the appearance of our first alveolus. So a terminal bronchiole is going to have the same characteristic of a bronchiole. It is a bronchiole. So we're going to continue to see that same characteristic. We're just putting it there as kind of as a placeholder. And then when we move to respiratory bronchiole, we add an additional epithelium.
So it's important to know proximal.
Well, just the terminal bronchiole is proximal. We have to pass through the terminal bronchiole to get to the respiratory. So, but we have to see the respiratory to know that what we're looking at is terminal. Okay. So what additional epithelium do we add to the respiratory bronchiole? Simple squamous. All right. So epithelium is going to be simple cuboidal. And then in the alveolus portion of the respiratory bronchiole, simple squamous. Right. That's why it is a respiratory bronchiole, because diffusion can occur at that location. Still no cartilage. What about smooth muscle? Only where we have simple cuboidal epithelium. So the smooth muscle is going to be present only with simple cuboidal epithelia. So it's going to be absent where we have the alveolar walls. Okay. So here's kind of an oblique section. Here we would have some bronchiolar walls with an alveolus here, a little bit easier to see on actually this previous slide that I had up there. So now we're going to move from respiratory bronchiole to our next structure, which is the alveolar duct. It's basically the way I describe it is to imagine a long, wide hallway formed of simple squamous epithelial walls. Off of that hallway are rooms. The doorways to the rooms are almost as wide as the roof. As you walk down that hallway, you're walking down the alveolar duct. The wide rooms off would be individual alveoli, similar to coming off of a respiratory bronchiole. Except the walls of our alveolar duct have very little, if any, smooth muscle, and no simple cuboidal epithelia. Okay? This is not the limit of our room. So again, here's a schematic diagram of it. So here would be the alveolar duct. Here would be the wide rooms or alveoli coming off of them. But that's not the limit of the airflow, because once the gases flow into those alveoli, they can flow into isolated alveoli through these smaller openings known as alveolar pores. Okay, so it's just, we're starting now to get into additional surface area. Yes?
Where does it go after it goes out the pores?
It goes into other alveoli.
Does it go into another pore?
Yeah, so that was my next question. What advantage does an alveolus have over an alveolar duct? Why don't we just stop with alveolar ducts?
There's only one right now.
Surface area.
Surface area. One of the problems with emphysema, which is a chronic obstructive pulmonary disease, is that the alveolar walls break down. And so you end up with actually increased lung volume. But instead of having this surface area here where we have blood vessels available for gas exchange, you would have just these walls and a greater diffusion distance for gases that are in this area. So alveolar ducts are still primarily, even though there can be gas exchange along the walls of it, they're still primarily an airflow. They're part of our respiratory zone because gas exchange can occur at the wall, but they're so wide that they're not very efficient at that. So we want to have a greater surface area to volume ratio, and we see that in the alveoli. Yes?
The picture
Oh,
on the
okay.
left looks like there's more of a wall on the histo side. It doesn't.
Yeah, it's showing it as a darker color, but the thickness is actually the same. It's still the same simple squamous epithelia. All right, the comparison of tissues up here. Can I erase what I have on the board so I can put those two new terms up? Before I do so, however, remember that these structures right here, ending with the terminal bronchial, belong to our conducting zone because they do not have simple squamous epithelia. So this is the conducting zone. And starting with our respiratory bronchial, including the alveolar ducts and alveoli, we have our respiratory zone. As soon as we have the presence of simple squamous epithelia. Oops, are you done? Sorry. So continuing with our respiratory zone, we would have the alveolar duct or alveolar duct with squamous epithelia. Still, obviously, no cartilage. And if there is smooth muscle, it's isolated in little corners, like maybe here or here, all right? But if I were to ask you a question, is smooth muscle characteristically present? Is it a characteristic structure of the alveolar duct wall? The answer would be no, okay? So now the next structure we're going to look at is the alveolus, or alveolus. So here's a diagram of several different alveoli. And these are the alveolar pores. Okay? So now the airflow going from one alveolus to another is going to pass through these pores. That gives us an increased surface area. We're not losing wall space for that. And so it's still a unit. It's still going to go through this pore into this alveolus, and then have to go back out again to go back out the alveolar duct and back out the bronchioles and so on to get back out to the nasal cavity and back to atmosphere. Yes?
Rewind for a second.
Uh-huh.
So, in emphysema, the surface area, it's all those are damaged. So when they have a lobectomy, that's why the breathing is better because they're taking all the dead space out. So they're reducing their
Right.
volume. So that's why it
One of the major problems with emphysema, similar to asthma, is breathing out. Because they have to collapse all those spaces. But that is a functional part of pulmonary ventilation. But as far as the gas exchange is concerned, it is the lack of the wall tissue. Because those break down. And you have actually an increased lung volume, but decreased surface area.
So getting the lobectomy corrects that issue.
Partially. Yes.
Is it also essentially, just so I can understand a little bit better, two balls, two spheres of simple squamous? Like each sphere would be an alveolar?
I'm not sure what you mean by two spheres.
I'm trying to figure out how this is structured. We've got capillary in between, and I'm thinking it's supposed to be one cell layer. So you have simple squamous.
Okay, so
on
we
one
draw
side
it
and simple squamous on the other.
three-dimensionally. You would have this with the pore, and it would have connective tissue around it. Okay.
Basement.
It would say that that's going off to an alveolar duct. And then from that one, you still have connective tissue. I'm trying to create the presence of that. And our blood vessels would be there surrounding it. Let me move on to another image here that here. You have this in your lecture notes. I don't want to go to you yet. But on a different page. And we have this as a model. Unfortunately, the blood vessels are in the wrong place and colored the wrong structure. So here would be a respiratory bronchiole. Here would be an alveolus with the blood capillaries associated with that. And then we get down to here, and here are all the individual alveoli.
Mm-hmm.
The sphere you were talking about.
Right.
With blood vessels and loose connective tissue around each one, but openings between them through those pores.
Okay, so they are kind of layered a little bit.
It's very similar next time you eat a cluster of grapes. Okay, so the stem of the grapes would be like still our respiratory bronchial or alveolar duct structure, but those grapes would be the individual alveoli. And if they were connected together, it would be more like the pores. Okay. All right, so coming back to this diagram, then let's diagram out the wall structure. Let me finish our chart here. So the alveolar epithelium is going to be just like the epithelia of our alveolar duct, simple squamous, no cartilage, no smooth muscle, period. Okay, not even occasionally, in the wall of the alveoli. Now, there's certainly smooth muscle in small arterioles around there, but not in the exchange area. All right, so now I'm going to kind of diagram this structure that you see on the board, on the screen, because the relationship between the alveolus and the capillary forms a structure known as known as a respiratory membrane. And that's a sandwich of two simple squamous epithelial tissues. So let me draw the alveolar structure first. So we have a simple squamous epithelial cell. With its nucleus, probably several. So this epithelial cell is identified as a type 1 alveolar cell. And that's just an alternate name for the simple squamous epithelium. Okay. In addition to that, kind of inserted, we have a type 2 alveolar cell. Actually, let me put this up higher where you guys can see it. We have a type 2 alveolar cell, which is a secretory cell. And lots of lipid droplets. And this is identified as a type 2 alveolar cell. actually too short and fat to function in diffusion. And its purpose is to secrete a lipid, hence the lipid droplets inside the cell, known as surfactant. This is not found in the alveoli of, say, a fetus that's 6 months old or even 7 months old. All right, but starting about 2 to 3 weeks before term, this lipid molecule starts to be secreted into the fluid-filled spaces of the fetal alveoli. Its purpose is to coat the surface with oil, which doesn't mix well with water, and remove the potential, decrease rather, the potential for the formation of hydrogen bonds. You guys remember from Bio430? Different types of bonds. One of the weakest forms were hydrogen bonds. Hydrogen bonds form between hydrogen ions and electronegative ions, such as nitrogen or oxygen. So in this case of water, it would be, we have the hydrogen, oxygen, and hydrogen ions, and the hydrogen bond then would form between one hydrogen ion and the oxygen ion of another water molecule. And this squiggly line would be the hydrogen bond. Okay? If you were to take a glass of water and put your finger on it, touch the surface of the water, and then slowly lift your finger up, you would pull the surface of the water up because of the hydrogen bonds from the water coating your finger and the hydrogen bonds still within the water. That's going to, it's very weak, it's going to break soon, but you're going to be able to, that's why you can lift the surface of that water, is that surface tension. Okay?
So surfactant.
Surfactant, by putting oil in there, when the baby takes its first breath, that surfactant then flows and air moves into the alveolus. That surfactant then coats the lining of the alveolus with lipid, this lipid surface. So when the baby first, the newborn, first takes a breath, it has to break all those hydrogen bonds. Now in adult, the surface area of an adult lung, all the alveoli in an adult lung, is almost the size of a tennis court. Of course, in a newborn, that's going to be less than that, but still, if it was a quarter the size of a tennis court, when you think of the number of hydrogen bonds that are there, even if it's not much energy, that many takes great force for the infant to have to open up, break all those hydrogen bonds to expand and allow air to be pushed into the lungs. Then it breathes out. What happens? Those alveolar sacs collapse like a wet plastic baggie, and without surfactant, those hydrogen bonds would be formed. And the same amount of force would be required every time that infant took a breath. So with premature infants, they often go into what's called respiratory distress syndrome, RDS, because they're using all their energy trying to break these bonds. Treatment can be, if they know that the infant is going to be born early, they can give the fetus precursors to surfactant. After it's born, they can provide inhalants that are sprayed into the baby's respiratory tract, and it breathes it in and it sucks it down into the surface lungs. Plus, they put the infants into what are called positive pressure incubators. And so the pressure is increased. So when the baby takes a breath, it doesn't have to increase its lung size as much, and the atmospheric pressure is higher and pushes the airs in, pushes the gases in with a bit more force, helping to expand the lungs. The baby's not using up all of its energy to do that. Right? Now, another cell that's present on the surface is a mobile cell. It moves around, right? And this is the alveolar macrophage. It's a monocyte that is matured to be a macrophage. All the other macrophages we talked about were primarily in loose connective tissue or in lymphatic tissue, like a lymph node. One place we talked about them being in the blood was in the liver. Want me to draw that up higher? I'll draw that up. It's also known as a dust cell. Okay? And it is just under the surfactant. So it's not in contact with the dry air directly. All right? But it moves around within the alveolus. It's shown here. In fact, it can actually get back into the blood. I read a study a few years ago where individuals that had a heart attack, if they had pneumonia subsequent to the heart attack, had an increased risk for a second heart attack. And research linked that to macrophages that had picked up bacteria, if it was a bacterial pneumonia, and moved to the heart and carried those bacteria into the heart where they cause additional structural damage. So the macrophages can move back and forth and aren't limited to being just in the lungs. Now these macrophages are still taking up particulate matter, so it's very fine. Our large dust particles and minerals and stuff usually get stuck to the mucus of our airways. These are non-biotic materials or non-living materials, and so the macrophages don't have enzymes, they're not proteinaceous fibers, they're mineral fibers or metal fibers, and the macrophages can't break them down. So an individual with miner's lung or asbestos will have those asbestos fibers or coal dust in the macrophages from years and years and years of exposure, because they can't break them down.
So if you didn't have those mesothelioma, that's what that would have to do with those
Mesothelium actually is the flora on the outside.
on the outside.
Right. Okay, so those three cells are the components of the wall of the alveolus, and now we'll look at its relationship with the capillary. Yes, Rachel?
If you can't break this stuff down, then what happens to the macrophage? It just keeps growing, or what?
Well, this just keeps filling up with that material, and then it can undergo damage. Yes?
Which one is the septal cell?
The septal cell is the alveolar type 2 cell, is another name for that. Dust cell is another name for the alveolar macrophage, and septal is another name for the alveolar type 2, the lipid secreting cell. So I'll put that up here in parentheses.
Each sac has one macrophage?
Oh, more than one. It's just one shown in the, yeah. I put two in this one. All right, so this is where this is the terminal destination of the gases that you breathe in. And so there will be a higher concentration of oxygen at inspiration than carbon dioxide. And that we want that oxygen to diffuse into the capillary, which I'm going to draw in black because I don't have red with me. But remember, capillaries are also made of simple squamous epithelia. And so we have the nucleus of the simple squamous epithelium is directed away from its closest apposition to the alveolar epithelium because that would interfere with distance. So this would be a pulmonary capillary. And we call these cells endothelial cells. It's just the name of a blood vessel lining simple squamous epithelium. And there's a little bit of connective tissue. There's certainly basement membrane. These are epithelial tissue. So there's basement membrane of these two epithelia. So down here would be basement membranes, maybe a little bit of connective tissue, collagen fibers, but no fibroblasts. That would make our distance too big. Maybe some collagen fibers. And so this sandwich of the two epithelia and the tissue between is is identified as a respiratory membrane. That's the wall, if you will, that the gas exchange has to occur across. When we get to the kidney, we'll talk about a filtration membrane, which is a similar sandwich that the molecules that are being filtered across out of the blood have to cross. So that's what we're seeing right here. Okay? This would be the respiratory membrane. The simple squamous epithelium, the type 1 alveolar cell, the capillary simple squamous epithelium, and that's what the gases are crossing. So we call that exchange of gases, that process of the particle movement of the gases, is known as diffusion. That's what we'll start talking about on Thursday when we talk about external respiration, gas exchange. So the process occurs by diffusion. And what are some of the factors that you remember from Bio430 that affect diffusion rate?
Pressure.
Okay, permeability or solubility. And as we'll see on Thursday, oxygen and carbon dioxide and nitrogen have different solubilities across the plasma membrane. The concentration gradient. So typically we have oxygen in higher concentration in the alveoli than it is in the blood. And carbon dioxide would be in higher concentration in the blood than it is in the alveoli. Now, you mentioned solubility. This is kind of for free right now because I'm going to talk about it again on Thursday. The concentration difference between oxygen in the alveoli and oxygen in the blood is about 104 millimeters of pressure for oxygen in the alveoli. I'm going to have to write this down and so you can actually know, so we'll talk about it on Thursday, to 40 in the blood. So it's going from 100 to 40. That's its concentration gradient. Concentration gradient for carbon dioxide is 45 to 40. That's not a very high concentration gradient difference. The reason that it can still move out of the blood is carbon dioxide is so much more soluble across the plasma membrane that it's barely a hindrance at all. So it doesn't need a high concentration gradient and it moves quickly across that membrane. Okay? What's another factor? Affected by pneumonia, pulmonary edema, pulmonary fibrosis. What am I changing when I mention those pathologies? Thickness, distance, yeah. So diffusion distance, which is going to be equal to the thickness of the respiratory membrane. All right, so if someone has pneumonia or pulmonary edema in which they have increased fluid at this area right here, increasing diffusion distance, we can partially, if not completely, overcome that by changing these factors. Very difficult to change the permeability of the gas, but we can increase the concentration of oxygen. So we can give them oxygen by mask or by nasal cannula. Either increase the concentration or make it 100%, and a higher concentration of gas particles here will help to overcome that increased distance by increasing the rate at which it moves. Okay, so some of the factors why we use those changes and aids in individuals that have difficulty with gas exchange. Yes.
So what are the like breathing treatments with like albuterol and stuff too?
Okay, that changes. Remember when we talked about factors that affected peripheral resistance of blood flow? And it was the diameter of the blood vessels, the viscosity of the blood, and the length of the blood vessel. Same factors affect airflow as blood flow. So we have viscosity of air. So you go up at 20,000 feet, it could be thinner than, say, a polluted smog area. but the most important factor, like it is in blood vessel, is the diameter of the airway. And so with asthma or irritants causing autonomic reflexes to constrict the airway, plus with asthma there's mucus secretion. And so salbutamol is a sympathetic agonist, sympathomimetic drug that binds to the same receptors as norepinephrine and relaxes those and increases the diameter of the airway. So it's at the conducting component rather than the gas exchange surface, because that's what's affected by asthma, is the airway constriction. On Tuesday as well, we will talk about restrictive pulmonary diseases and obstructive. And that approaches the surface area versus the airway diameter difference in those drugs. So asthma is an obstructive disease, pneumonia is a restrictive disease. Asthma changes the airflow, pneumonia changes the gas exchange. Okay. So here are some images of an alveolus, a little higher power. Here's a type 1. You can see the thin, simple squamous epithelia. Here's a type 2. Here's a type 2, or the septal cell. And you can see the large amount of lipid in there because the surfactant it's releasing is lipid.
Oh, yeah, okay.
Is it always releasing lipid?
Yeah, so it's not there and then done for your life. Then we have, here's another diagram. So you can see the phospholipid here with the surfactant, so the type of that little fatty acid tails coating that lining. We'll talk a little bit more about surfactant when we talk about factors that inhibit or increase lung expansion. Just another lipid cell. This will come back to. So now that this it was the image I referred to earlier. We have this model, looks almost exactly like this in the lab. The only problem is the way they painted it and labeled it. The blood vessels are all in the wrong locations and the wrong things, so I don't really bring it out because it's easier to just not learn it than to make corrections to it. But it does show the visceral pleura on that model, so I do show it to you on that aspect. But I bring this up here. This is an air sac. So respiratory bronchial, its alveolar ducts and all the alveoli are an air sac. An alveolus or an alveolar sac is just one of these. Okay? I unfortunately tend to interchange air sacs and alveolar sacs. So whenever I talk about an air sac, I'm really talking about this. I never talk about the whole cluster. If you hear me say the word air sac, I'm meaning alveolar sac or an alveolus. Okay? Just kind of a heads up. Now let's pull out of the lungs. And pull out of the airways and look at the lungs externally.
So Marcy?
Yes.
So you said the exchange of gases across the, is that the respiratory membrane right
Yes.
there? Okay, you said it's called diffusion, but then there's another term here that you're asking for on the...
External respiration is the name of the process where that diffusion is occurring. Is that what you're thinking about for that term? But diffusion is the membrane transport process that we use.
Okay.
So when we look at the lung tissue, okay, at the lung organs, you can see that they're found within a bony cavity created by the vertebra, the ribs, and the sternum. And what advantage does this bony cavity provide? Protection. Obviously, the heart has that same protection. But there's another requirement for these ribs that the heart doesn't require.
Space?
The heart could function if it was down in our abdomen. The lungs would not.
Oh, it pulls, doesn't it pull the lungs out when you breathe?
Okay, it changes the volume. It helps to change the volume of our thoracic cavity. And that changes pressure.